Welcome back. I hope you all had a nice little break, stood up, moved around, got a drink of water. Hopefully something healthy happened. Let the dog out, whatever you needed to do, and are refreshed and ready to move on to another topic. We in primary care deal with a lot of different things during our day, and it's not unrealistic to go from a serious illness conversation to a rash, and that's what we're going to do today. We're very fortunate to have Dr. Richard Pierce here today to talk with us about particular skin changes that would make you think of an internal medical issue. I think we all are worried, is it a rash or is it telling us something else? Dr. Pierce is in practice on James Island, and we are so happy to have him in our community for the last year. Thank you very much, and I'll turn it over to Dr. Pierce.
I'm Dr. Pierce. It's great to be here. My very short bio is I was a doctor in the Army for a long time, and I've been a doctor at James Island for a year. It's an honor to be here. We're going to talk about cutaneous manifestations of internal disease, which is a very broad scope and is oftentimes very confusing. My prime objective for this lecture is to try to break it down and make it as clinically relevant as possible. How do I do that? One, useful. I want it to actually aid in decision making. And what does that decision making mean? Well, you see this arrow that I have here, and there's a spectrum. You have things that are very easy to diagnose. You see them all the time. They're low acuity, things like onychomycosis. I'm really not going to cover that. You also have these things that are very easy to identify as concerning. Those are easy to refer. Things like paraneoplastic pemphigus. Someone's skin is boiling off 70% of their body. It's very easy. You know that you need to intervene. You're going to get other people on board. You're going to refer. I'm not going to get too much into that. Where I want to focus on is that gray area where diagnoses are missed, where there's diagnosis of, there's cutaneous manifestations of internal disease that mimic other common skin disorders, and that's where mistakes are made. That's where I want to try to sort things out for everybody so that you're getting those diagnoses correct, and that's often very simple. And that's what I'm going to do. The second thing my goal is to make it simple. I want to use very simple clinical signs, usually just a single clinical sign that you can use to differentiate a concerning thing from a common non-concerning thing. If we can make this memorable as well, that's great. I can barely remember 2 years ago what I did for CME, including conferences that I went to. If I remember one or two things from the entire conference, I feel I did a great job. So if I can just get you to remember one or two things 12 months from now, that's great. And non-comprehensive, if you emphasize everything, you emphasize nothing. So let's get right into it. All right, this is diagnosis one. My understanding is that you guys can type in, we can do sort of a question and answer format where if I ask a question, you guys can type in. Dr. Scott may be able to tell us what the responses are. We'll try that out. If it doesn't work, we won't do it. But here's diagnosis one. This is a 50-year-old patient. He came into my clinic about 3 months ago. His history was he has had this condition, these symptoms for about a year. He has these pink, itchy bumps on his arms, his abdomen, his leg. He was, someone did a culture and it came back as MRSA, so he was treated with TMP-SMX. That didn't help. He was then diagnosed and treated for scabies. That didn't help. And then he came to see me. The things that you look on an exam for this are, he's got these sort of erosions and excoriations on his arms, in addition to the papules on his arms, his feet, and his abdomen. His chief complaint is these spots itch. They show up and they itch. Does anybody have any idea what this might be? We'll see if we can get responses in time. I'm going to say no, so we're going to move on. There's another manifestation where you see the bumps on the legs.
Actually, Dr. Pierce, we have a comment of liver cirrhosis.
Liver cirrhosis. I see where you're going there, and that could be there because you're going that this is chronic. Certainly, liver cirrhosis can cause pruritus. Pruritus could be a contributing factor to this diagnosis. I like where your head's at. We're going to get a little bit more specific. Where you notice here, we have all these bumps on the legs, but in addition, almost all of them also have these erosions on the top. This is Prurigo nodularis. This is a diagnosis that is all over, but you never see it anywhere, rarely mentioned in medical education. You hear, palpable purpura for HSP all the time. Like every medical student is this sort of, that's hammered into them. But you never hear Prurigo nodularis, and you'll see it all the time. In summary, what is it? It's basically when they have itchy skin, they're scratching it, and all of the lesions are secondary. They're not primary. So there's different forms of things that could cause pruritus, like cirrhosis of the liver. That's less common. Typically what it is is atopic dermatitis, but also anxiety and depression. There's a 50% overlap with this condition, with atopic dermatitis, and even higher with anxiety and depression. So what you're going to see is it's the rubbing of the skin causes the thickening of the skin. Lichenification is the fancy term, but I wouldn't remember that. I would just know, like a callus, you rub the skin, it's going to get thicker to protect itself. So what do we do for this? If you look at the editorial part of the slide, that's where you kind of get my comments that you won't find anywhere. Is the first encounter you're going to build trust, because since these are secondary, the patient's inducing it on themselves, I don't lead with that. Typically what I tell them is I give them the diagnosis of prurigo nodularis. We're going to treat a very small area, perhaps just one section of the arm. What do? High potency steroids, and then you do occlusion and protection. The high potency steroids will reduce the irritation and inflammation, and the occlusion and protection basically will keep the patient from pawing at it. Now there's a very fancy way to do occlusion and protection. You can use Cordran tape. Insurance, very expensive. You're looking at $700 to get that. Most insurances, won't cover it first line, and when it does get covered, there's a huge copay for the patient. So my simpler solution is you replicate that by using something cheap. You use clobetasol ointment and put a Band-Aid over the top of it. You've spent pennies and you're getting the same effect. So what you do is you pick a small area, cover it up, do the steroid, have them come back in 3-4 weeks. That will get better, and now you have patient buy-in. They believe that you can actually make this better despite the fact that they've been treated for everything else. Then at the second encounter, what you do is you sort of use the trust that you've gained by demonstrating proficiency. You bring in, you talk about the anxiety, the depression. I would generally have to collaborate with you guys as the PCMs to have you help manage their anxiety. And then you basically go more widespread. You'll take, instead of using Band-Aids, you'll use the clobetasol, and you'll start using occlusive sleeves, such as this. So here's the patient. He had this for over a year. He came here, we did Band-Aids and clobetasol, convinced him that's what it was, and then he used these compression sleeves, had them on his arms and on his legs. Yeah, he wasn't looking cool the whole time, but he did get better. You can see, his right arm was better, his legs and his left arm did equally as well. So, prurigo nodularis, you'll see it all the time, anxiety association and atopic derm. Here was a patient that came in. She had been diagnosed with psoriasis, had been worked up for lice, got nowhere. I had a suspicion that she had some anxiety and depression because the first time I met her, she was crying the whole time. So it was a subtle tell. But what we did for her was, I can't put Band-Aids in her hair, so we did the clobetasol, and I had her wear a swim cap or a knit cap for 3 weeks, and she got better. So it does work. Right, this is similar, but not quite the same. This is diagnosis number 2. Here's a patient. You can see that she has sort of these hyperpigmented, thick, we might say lichenified, a fancy word for thickening of the skin. On her back, notice that there's a portion that's not affected, her shoulder blades. That's interesting. Here's another patient. Young woman, she has, I don't know, what are those acne-like lesions on her face. If you look under her right eye there, she has what might be a primary acne lesion, but that's not really what's bringing her in. Look at her forehead, look at the rest side of those cheeks. You see those erosions. Is that HSV? Does she have a blistering disorder like bullous pemphigoid? Probably not. There's probably a better explanation. And this is the real archetypal example of what this condition is. And you'll see that this patient has a bunch of erosions on her face. But if you look at that lesion on the right side of the chin, classic. There's no other thing that's going to do that. That linear erosion, that's an excoriation, kind of in the same vein as the last diagnosis. These are neurotic excoriations, compulsive skin picking. If you suspect this, I don't recommend you go with neurotic excoriation or even compulsive skin picking when you're describing the diagnosis to the patient. It generally doesn't go well. I tend to say, we'll bring that up at the second encounter. What are the associations? What are the internal manifestations that cause this? Again, these are behavioral health. Anxiety, depression, obsessive compulsive disorder is, almost always associated, underlying with these patients. So how do you do this? You're going to build trust with the patient, and then you're going to get a relationship with a dermatologist. As opposed to the first diagnosis, which was prurigo nodularis, like when you go to the dermatologist with that, there's a lot that the dermatologist can do. We could do a biopsy that will convince the patient, because if you do a biopsy of a prurigo nodule, the pathologist will say, prurigo nodule. Biopsy of an excoriation, It's going to come back with this broad differential. It's going to say excoriated tissue with neutrophilic infiltration. It's not going to be specific. It's not going to convince the patient of anything. What we can do is say, well, these lesions are secondary. There's probably something else going on, and try to get some more buy-in for the patient. So, well, for prurigo nodularis, your dermatologist will probably, take the wheel and, drive that patient's treatment. For neurotic excoriations, compulsive skin picking, this is more of a manifestation of the anxiety or the depression or the OCD. So the primary care doctor or the behavioral health provider is going to be in charge, and the dermatologist is going to play an assisting role. So, the treatments, you're going to treat the underlying disorders. You're going to use SSRIs or a second-generation antipsychotic, and then again with occlusion and protection. This is more recalcitrant to treatment than the previous diagnosis, but what's the one thing I want you to remember about this diagnosis that I think most people can apply? That's going to be that excoriations are not primary. If you see somebody with what's clearly picking of the face, they have these erosions, probably not bullous pemphigoid, probably not HSV based on the distribution of it. You see those linear geometric excoriations, it's secondary, start thinking about what could be the primary problem. Okay, do manifestations of psychiatric illness fit into the chapter of internal disease? I'm putting them there. If I'm talking to a large audience of primary care doctors, I feel I would be remiss if I didn't bring this up, because this is actionable information. We could intervene earlier. It's much more common than you would expect, and it's often misdiagnosed. So if I have an opportunity like I have now, I'm definitely going to intervene and let primary care doctors know that this is something you should be on the lookout for. All right. First two were sort of behavioral health manifestations. Now we're going to switch gears, go more medical. Here's diagnosis 3. This is a patient who came in. You can tell I took the photograph because it's not that great. It's out of focus. I didn't even take the gown off the patient. I'm covering up the pathology. I didn't know I'd be presenting this, but it's there. She had this for a year. It was photo-induced rash, always there. Worse in the summer, pink, mildly pruritic. Had been treated with topical steroids for a year from various people. And then she came and saw me. Here's another manifestation of, we'll say, this third diagnosis. This is more prototypical. You have a patient here. She's got red bumps on her cheeks and her forehead. What is this? Is it acne, rosacea, something else? I don't know. I could be convinced of either one of those in the right setting. But this is the prototypic diagnosis they would see for this condition. Here you have this malar rash, the so-called butterfly distribution. It's more of a...
Some comments of lupus.
Well, very good. So you picked up, see, there's certain sort of buzzwords that if you feed to someone who's medically trained, they will just like hit the answer button. One of like palpable purpura, bam, you say HSP. Malar rash, butterfly rash, boom, lupus. I'm glad that you guys got that. So, all right, acute cutaneous lupus. All right, think. Cutaneous lupus could be its own lecture. I'm going to get through this pretty quickly and just give you the high points, right? I really want you to focus on acute lupus. This is not comprehensive, but I'm going to give you that gray area where I see mistakes made. And I want you to, one thing that you would remember is just know that the different forms of cutaneous lupus have a different rate of association with SLE, and that's what the patient really cares about. Acute lupus, you're looking at 90 to 100%. For subacute, it's about half, and for chronic forms, it's infrequent. 10%, maybe more. There are some factors that are at play there. Okay, so here's this patient. She has the malar rash, the one on the left. That's pretty profound. I mean, it looks like she put swim goggles on and someone put squaric acid on her face. But this is actually, an acute lupus malar rash. You won't see that too often, but the right side of the slide there, that's the more prototypic rash. But what I want to point out here, the thing that I think a primary care doctor should look at and learn from this lecture is, how do you know it's a photo-induced rash? A couple of hints. One, look at the picture on the right, that's more prototypic. It's sparing under the nose. It spares that periorbital distribution. The eye sockets provide shade. They photoprotect. So you're not seeing as much involvement there. So that's like a high yield tip. Sparing of the periorbital area, you want to think acute lupus, all right? The other forms of acute lupus, what is photodistributed? I don't want you don't have to remember the photodistributed maculopapular, but this is a good opportunity to talk about what's photodistributed on the body. Photodistributed on the body for a female patient generally looks like a tank top. So if you put a tank top on them, it's going to spare that area. The other areas of involvement you can see here. Typically, it's not going to be so beautiful as this, where you get It's a perfect photo distribution. Usually you get some of the neck, you'll get some of the dorsal forearms, some of the hands, or you'll just get the dorsal forearms and hands. But this is what photo distributed on the body would look like. Acute lupus can be really bad. You can get this like a bullous lupus, or you can get a toxic epidermal necrolysis type form. Don't try to remember this other than the fact that this is an example of that far right side on the spectrum where there's no question that this needs to be seen by a specialist. You're going to send them to the emergency room. I wouldn't commit this to memory. If someone's skin is boiling off, you know what to do. Ask for help. All right, subacute cutaneous lupus. Typically you get this polycyclic thing. What's the one thing I would remember about subacute lupus is that it can be drug induced. So if you put someone on a medication and then a couple weeks, 2-3 weeks later, they look at this rash here and you're probably thinking, geez, I gave them an antifungal and now all of a sudden they've got more fungus. This is really serious. Consider subacute cutaneous lupus erythematosus. It can have about 36% association with drug use. The list is long. The ones I see most commonly are antifungals, griseofulvin, terbinafine, TNF-alpha inhibitors, but a lot of the diuretics that you guys are using all the time can induce it. How do you narrow it down? The time course and usually the patient. This is a significant emotional event for them when they get a rash like this, and they will kind of do their own due diligence and say, oh yes, well my doctor treated me with terbinafine 3 weeks ago, so a lot of times they'll tell you. Another form of this that's a little bit deeper, not quite as obvious, but you can kind of see those polycyclic. Polycyclic just means multiple, round annular lesions. All right, chronic lupus, you will see this more often, not usually associated with systemic lupus, but look at this. This is the prototypic diagnosis. It almost looks like scarring. We see you get this pink scar of lupus. This was a patient walked into our clinic 3 weeks ago, had been admitted to the hospital, was treated for infection and seborrheic dermatitis and a bunch of things that weren't lupus, but yeah, what she had was chronic lupus. All right, on this slide here, focus on the blue box. So the first three things, all the forms of lupus that we talked about, those three, if you did a biopsy of those and you sent them to the dermatopathologist, they're going to give you the diagnosis of cutaneous lupus. However, there's some things that are associated with lupus that are also associated with other things. So they're not specific to lupus, those skin-associated things. That's in the blue box. The ones I want to draw to your attention is going to be the livido-reticularis, because this comes in all the time and patients are way more worried about this than they should be. What is livido-reticularis? Well, reticularis means net-like, and you can see in this photograph you get this mottled red pigmentation. Can this be associated with connective tissue disease? Can this be associated with antiphospholipid syndrome? Sure. Is it usually? No, because this is physiologic. If you have small children or babies, you'll see that they have this all the time. Why does this form? You'll see it on the thighs, especially in fair-skinned patients. This is a physiologic response that has to do with a vasoconstriction that your body does to try to preserve body heat in cold weather. So when do you, do the full shotgun lab workup, and when do you say, hey, no, I think you're okay, this is physiologic? If it resolves with rewarming, it's probably physiologic, and you don't need to shotgun their labs and get them all concerned. All right, gray area. What are the things that I think I can give you value of where there's a lot of overlap and that people tend to mess up? That would be, acute lupus, sebderm, and rosacea. So on the left of your slide, we have that's rosacea, that your two friends in the middle, they have lupus, and on the right we have sebderm. So let's try to sort this out, because I have seen sebderm being treated with Plaquenil, and I have been seeing lupus being treated with ketoconazole shampoo. All right, so rosacea and the malar lash of lupus are the most alike because they're both photoinduced. They both have that photo distribution on the face. How do you differentiate rosacea? I think the best thing is rosacea is going to have pimples, right? Acne-like lesions. Malar lash of lupus won't have that. The other thing you can do is if they have, other rashes on their photoinduced rashes on their body, rosacea won't do that. And then if you're just really not sure, you didn't remember, just give them the treatments for rosacea. Give them doxycycline, low-dose doxycycline, give them Metrogel or azelaic acid, and if it gets better, it's not lupus. All right, seborrheic dermatitis. This is a public service announcement because the seborrheic dermatitis is out there all the time. You guys know this. And it can vary in intensity of its presentation so widely that you can have someone come in, their entire face and chest looks like it's red, and it looks like it's something serious, but it's not. So here is my very hot tip. I said simplicity. You can make this diagnosis with a single finger. All you do is you take your thumb and then you rub the patient in between their eyebrow. And if it starts flaking, it's seborrheic dermatitis. That's the inducible scale. You're still not sure? Take 2 thumbs, rub the sides of their nose and their face. You get inducible scale. That's rosacea. Case closed, bring in the next patient. It doesn't mean that they don't have concomitant conditions in other places, but they definitely have seborrheic dermatitis. One other, this is my quick tidbit, can't not give this out. Treating seborrheic dermatitis. We all have the same tools. You have ketoconazole shampoo and selenium sulfide, and that's what I have. Here's the key. It's caused by Malar furfur. It is it's a dimorphic yeast. Well, since it's dimorphic, it's yeast and fungus. So what you need to do is you give them the ketoconazole shampoo, or you give them zinc pyrithione, which is Head and Shoulders. Shampoo your face, shampoo your scalp. Leave it on for 5 minutes. It needs that contact time. Leave it on for 5 minutes, rinse it off. If you want to be really motivated, shampoo that into their hair, have them rinse out 70% of the suds, leave 30% of the suds in the scalp, have them dried in with a towel. Now you have a residual that's going to be there for hours instead of seconds, and it's going to work. So implement that. But if you do that and then you send me a patient and say, yeah, sebderm, I'm out of, I don't know what else to do. So if you do that and it doesn't work, I can't do much more. All right, gray area. All right, lupus, rosacea, sebderm. So my overall tip for this is, if you have what you think is chronic, sort of recurrent photoinduced rash, think sebderm, think rosacea, and if you've kind of ruled those out, then it's time to start thinking acute lupus. Here's that other patient. She came into the clinic. She's getting better. Here's this patient. Now, I brought this up as the first case, my very poor photograph on the left. I did a little bit better on the right. She had a form of acute lupus that's an overlap with cutaneous mucinosis called reticular erythematosus mucinosis. What did you do? I put sunscreen on her chest. And then I also gave her some Plaquenil for 3 months, and she got better. She has some hypopigmentation. It's the best I can do. She's pretty happy with that, but that's as good as it gets. So the erythema is gone. All right, that's what I said about cutaneous lupus there. Think of the common things first, then think lupus. All right, diagnosis 4. Here we have sort of the inverse of what we talked about last time, sparing of the eyes. Now we have involvement of the eyes. What could be going on here? If you think you know, already start typing in the answers so we can get that. Here's another form of this next condition. We've got some, pink bumps over the knuckles here. We have them, they look to be over the joints, kind of wart-like in appearance. That's strange. I don't know, is this psoriasis or something? Does anyone have any thoughts?
Someone said eczema.
Eczema, I like where your head's at. And that is going to be one of the things we sort this out from. But dyshydrotic eczema of the hands is certainly a very good thought. This is why we're going to sort these things out. This is dermatomyositis. Another autoimmune condition, just like SLE. There's some skin-specific findings. There they are. I don't think you really need to remember the names of what each one is. Just know what they look like. That's what's important. You don't make the diagnosis by remembering the names. You make the diagnosis by actually knowing what it looks like. So the heliotrope rash is where they get the redness on the eyelids. It's not always photo-induced. You also get these Gautrons papules, basically wart-like bumps on the hands, dorsal hands, and that's what our initial picture was of. Here we have the shawl sign. Why is it called shawl sign? Because you get it around, imagine you wrap a shawl around your neck. Where's it going to touch? Your neck, front of your chest, top of your back. You also get ragged cuticles. This is in here more for completeness. I don't expect a PCM to ever sort of diagnose ragged cuticles. It's dilation of the capillary loops on the proximal nail fold. It's kind of a gee whiz thing. I have never seen it myself. Mechanic's hands. This is a tough one. I don't think anyone's making this diagnosis without a biopsy, but this really looks like eczema. And great, the gray area, whoever typed in eczema, thank you, because you're really helping me make the point that these hand rashes confuse everybody. It's dermatomyositis, psoriasis, dyshydrotic eczema, and tinea. They get confused all the time. Very simple to sort out if we can make it simple enough for you. So hand rash, let's go with #1 most confused diagnosis, with the exception of maybe the groin rash in men. Like that is never diagnosed correctly. But back and forth, hand rash, groin rash, we'll figure this out. All right, someone said dyshydrotic eczema of the hands. That also has the name of Pomflox. I would ignore the Pomflox. It's esoteric, academic term, and that's not what we are. We are more frontline primary care. So let's just call it dyshydrotic eczema because that's more descriptive. Dyshidrosis, they don't have natural moisturizer. Eczema, it's an eruptive rash, so they get this on the hands. So simplicity, what do you need to know? It's dry skin and inflammation, but if you look on the acral borders of the hands, so this is the hot tip for dyshydrotic eczema. On the acral borders, that's where the fingerprint-looking skin and the non-fingerprint skin meet, right on the sides. If if you read a textbook, it'll say they have little blisters there. They're not blisters. They look like little skin-colored bumps. Check each one of the fingers. If they have the bumps there, it's dyshydrotic eczema. Prescribe your clobetasol. Next patient. Nothing else does that. Okay. Now, dyshydrotic eczema of the hands is really sort of a form, the adult form of eczema or atopic dermatitis. So, when kids get atopic dermatitis, children, younger people, you get the textbook stuff. You're going to get the rash on the neck, the face, the flexures. How do adults? So 80% of people who have atopic dermatitis or have childhood eczema are going to outgrow it by the age 18. The people who don't are generally going to sort of transition into this form, which is nummular dermatitis and dyshydrotic eczema of the hands. Nummular dermatitis nummular means coin, dermatitis, inflammation of the skin. So you get inflammation that's round and annular. So look at the right side, that picture on the right where you see that round area of inflammation. And I'm not even going to ask, if I put that picture up there and I said, what is this? Everybody would say, that's ringworm. That's, tinea corporis, right? So here's a couple more pictures of the dyshydrotic eczema. On the right, hands, left, tinea corporis. Here's the thing that everyone's going to say that this is. That is, dermatomyositis or tinea, because it looks very similar. Look at that hand on the left. Look at the one on the right. I mean, another annular lesion with a raised red border. How do you tell the difference? I'll make it very simple for you. We talked about using a single finger. It's another single finger test. You just take the patient, all right? You have to have an ungloved finger. Don't worry. It's like tinea is you're not going to get it. You take your finger, take the glove off, and you just close your eyes and you rub it across the skin. If you feel rough skin, it's nummular dermatitis. If it feels smooth, it's probably fungal. It's probably tinea corporis. That one test alone will sort out the difference. Yes, I know you could do a KOH, but let's be honest, you don't have time for that. It's not going to happen. Close your eyes. Rub it. Oh, it's rough? That's eczema. It's smooth. Treat them for tinea. Now, you may sometimes, you get this partial response because you take 1% terbinafine cream and you put it on nummular dermatitis and it gets better. Well, that's because 1% terbinafine cream is 1% antifungal, 99% cream. So yes, you're moisturizing it, so it gets a little bit better, but it's not going to resolve it. Okay, so psoriasis. Look at this. This is very similar to the dermatomyositis looking hands because you notice that you're getting the plaques over the knuckles and the fingers. So how are we going to sort this out between dermatomyositis and psoriasis? Short answer, you're probably not. You're going to refer that. But if they have really bad fingernails, they're pitted, that would kind of tip you towards psoriasis. But if it gets to this, it's probably a biopsy diagnosis. Either way, so don't stress out too about this. Now, dyshydrotic eczema versus those mechanics hands of dermatomyositis, I wouldn't worry about it too much. It's very similar. If you've been treating dyshydrotic eczema with that high-powered clobetasol and it's not getting better and they have other sequelae of dermatomyositis, refer them because these are probably just too similar to sort out. All right, review up to this point. So we've done 4 cases, 4 diagnoses. The first 2 were both cutaneous manifestations of psychiatric disorders, and the last 2 were both connective tissue. So I want you to remember 1 or 2 facts a year from now, so I'm going to reiterate these. Prurigo nodularis, okay? Clobetasol and a Band-Aid. Do occlusion and protection. It will get better. Neurotic excoriations. Excoriations are always secondary, no matter how compelling that patient can be that these are primary and that they're not scratching their face. Excoriations are always secondary. Cutaneous lupus, know that gray area. Always think seborrheic dermatitis and rosacea before you start getting an ANA. 20% of the population has a positive ANA. So you will, I had a patient who came in, convinced she had lupus, plaque went over 2 years, positive ANA. She had sebderm. She was doing the lupus walks and everything. She didn't believe she had sebderm. I used a shampoo, she got better. All right, here's diagnosis number 5. Start thinking about typing in your responses on this. So now we're going more into the medical side, which I would imagine most of the primary care doctors are going to be more interested in here. But this person, their hands are red. And which part of the hands are red? Well, it's not the dorsal, it's the palmar. So this is palmar erythema. And they also have these red bumps in that, somewhere on their trunk. They could be on their face. And the way that those red, purple bumps present, you can see that there's sort of a big bump in the middle, and then they have these little tentacles coming off, almost like the legs on a spider. And my presupposition would be at this picture, if you took a CTA or a Q-tip or a pencil and you pushed on that central purple bump, the rest of it would blanch off. The patient may also have gynecomastia. So can anyone chime in with their answers?
Syphilis.
Syphilis, the great mimicker, can happen on the hands, but would not look like this cluster of symptoms. All right, I'm going to get a clue. Someone actually chimed in with this answer earlier.
Cirrhosis.
All right, cirrhosis of the liver. I like it. So this is cirrhosis of the liver. It can be. So how do you remember that this cluster of symptoms is associated with cirrhosis of the liver? Well, I'm going to give you an explanation, and this is one where, like, the dermatology and rheumatology professor at the academic centers, they'd start clutching their pearls, right? Because I'm going to simplify this, but I'm going to do it in a way that, is honest enough, and it describes the symptoms, and it tells the story but not the complete story, and that's estrogen, all right? Why would someone with cirrhosis of liver get this cluster of symptoms? Well, it's because of estrogen. Estrogen is metabolized in the liver, and if your liver is cooked because you have cirrhosis, you can't metabolize your estrogen. Estrogen has vasodilatory properties, and it also plays a role in angiogenesis. So what are you getting on the pulmonary erythema? You're getting vasodilation and some angiogenesis of the capillaries. Look over there. You have those spider hemangiomas, which are basically a blood vessel with some extra growth off it. That's estrogen inducing angiogenesis. The gynecomastia that you can see, why does that happen? Well, even in men, the breast tissue has estrogen receptors. It's become hypertrophic under the exposure to that extra estrogen, and so you can get gynecomastia as well. Where else can you get pulmonary erythema and telangiectasias like this? In a hyperestrogen state, the third trimester of pregnancy. So both cirrhosis of the liver and both the third trimester of pregnancy, you can get these findings, these cutaneous findings, because of the high estrogen states. So cholestasis of pregnancy, you don't have enough hepatic outflow, everything's backing up in the bile ducts, so your metabolism of liver can't do its job as well, can't metabolize estrogen, can't break it down, estrogen spikes up. On top of that, third trimester of pregnancy is organically a high estrogen state. So third trimester pregnancy, you start seeing pulmonary erythema, you start seeing these spider angiomas. It's because of the extra estrogen. In men, so can you really track the estrogen to see if it's cirrhosis? What is the association? They've tried to do it in patients in studies, and in men they try to track sort of the estradiol level against the free testosterone level. I don't think it's that important. At this stage in liver cirrhosis, you know that they're hurting, but it is something that you will see. All right, diagnosis number 6. Start chiming in if you think you know what this is as I start going through them. Left to right, we'll describe them. We got some, looks like, I don't know, what are those, bruises on the legs? They're poorly defined, which means it's probably a deep inflammation, so deeper in the skin. So start thinking, what could be in the deep part of the skin or just below the skin that would get inflamed on the shins? In the middle picture there, we have, what is that? A big ulcer or erosion. Most times that would be diagnosed as some sort of infection. You guys, this is cutaneous anthrax or something. And on the right, we have an ulcer in the mouth. The differential for that's fairly short, probably an aphthous ulcer, HSV. So we have this.
Pyoderma.
Pyoderma gangrenosum. If you were in the room, I'd give you a high five on that center one. That is pyoderma gangrenosum. Great segue. That's a neutrophilic infiltration into the skin. Neutrophils go in the skin. They start doing what neutrophils do. They release myeloperoxidase. It starts, killing all the tissue, self and non-self. So too many neutrophils in the skin, you get pyoderma gangrenosum. So does anybody know what we have on the left? Any takers on that? That's erythema nodosum. What is that? That's inflammation of the fat. Does the body need to be sending inflammatory cells to the fat in your shins? No, it's a mistake. There's too much inflammation going on in the body. Same is true of an aphthous ulcer, right? That's sterile. There's no virus there. There's no bacteria. Immune system's making a mistake. It's too much going on. Inflammatory bowel disease. Your immune system's attacking your guts, and then it starts attacking your skin. Now, it's usually Crohn's disease. Why Crohn's disease, not ulcerative colitis? Best way to think about it is ulcerative colitis tends to just be limited to the rectum and to the colon. And if you think, Crohn's disease, that can affect the entire alimentary canal, so why not affect more of the skin? It tends to be more of a generalizable condition, right? The other thing that you will get with inflammatory bowel disease, you get these perirectal fistulas and abscesses, but those are so profound that when you see those, that falls in the category of, oh, you better go see general surgery. You literally have a fistula right next to your anus. You're not going to manage that at the primary care level. So inflammatory bowel disease, this is how you tend to see that show up. On to diagnosis 7. All right, this is classic med school pay dirt. All right, so let the picture on the left, I know you guys see this diagnosis all the time because the prevalence is so high. So at any time, if anyone thinks they know what the unifying diagnosis between this thing is, type it up. But I'm going to start walking the dog here a little bit. Look at that picture on the left. That picture on the left, you see a couple features. The primary one, the skin pathology here, is they have this darkening of the skin. It's probably a little bit thicker. Could be described as velvety. I don't get that.
We have diabetes.
Diabetes, my man, out there. Great job. So yeah, this is, diabetes. You can see it type 1 and type 2. A couple of the things that you can see in your patients that kind of tip your hat is this. On that left side, there's more than just the acanthosis nigricans that you would see that would tip you off that this person may have insulin insensitivity. One, you can't see this person's clavicle. It's a female patient. You can tell because you got the longer hair, but you notice that the hair is starting to grow further forward on the face. So you're getting hypertrichosis. You're getting hair where you would not typically expect to see it. You can't see her trachea from the side. Her neck is not as defined as you typically would see. You can't see her clavicle there. What does that mean? Her BMI probably higher than what is ideal. These are things that would all point you to the DM. On the right side, so that's necrobiosis lipoidica diabeticorum. Don't remember the name. You can remember the abbreviation if you want, NLD. If you don't remember that, you don't have to remember that. Just know that patients who have diabetes can get this rash on their shins. If you take a look at it, you'll see it's pretty well defined. You see those white areas in the middle of the inflammation. That's atrophy. That's, the skin is getting thin there, and if it's not treated, it tends to get so thin that you get erosions. That is a bad thing. So with NLD or with acanthosis nigricans, what do we do to treat this? Well, of course, you're going to tell the patient, well, let's get your A1C down. Let's get good control of your, of your sugar. We want to have tight glycemic control. Great, that's good to do, and I'll recommend every patient that has NLD do that. Unfortunately, it tends not to improve these symptoms at all. This is a very recalcitrant to treat. You start with high-potency topical steroids, then you try to go to a steroid-sparing topical, because the primary problem with this is thinning and atrophy of the skin and the development of ulcers. So if you're pounding this area with clobetasol constantly, clobetasol doesn't typically cause atrophy. Everyone worries about it. You can use it a lot. But they're going to be using this for years in the same location, and it can accelerate the atrophy. So for this diagnosis, this is a referral to dermatology. This is a biopsy, and we're happy to help you out. All right, diagnosis 8. This is the last one. So when I got asked to do this lecture, this is sort of the ivory tower academic part of this. When I say it was non-comprehensive, this is the part where I would generally say, be careful with these types of cutaneous manifestations, because the common things can mimic them, and a lot of times they don't associate well. But let's just walk through these pictures. At any time anyone thinks that they know what it is, you chime in on your keyboard and we'll see how you do. On the left, picture on the left, what do you have there? You have these sort of stuck on, like,
Seborrheic keratosis.
Yeah, seborrheic keratosis. That's what those are. I mean, geez, I don't even want to talk about how many seborrheic keratosis I see in a day, because it's all I do. But those are very common, very normal. When they all show up at one time, sort of this eruptive seborrheic keratosis presentation, that can be associated with something. I don't think anyone's going to get this sign in the middle. The thing that you're seeing there is you get this sort of accentuation of the acral portion of the skin. The fingerprints, they get thicker. The patient goes, wow, why am my fingerprints getting really big? And then on the right side, what you're seeing there is, I don't know, look at that. I say, I don't know what's going on, and it looks weird. And the thing that sort of tips you off that's a little bit different is that skin's really shiny. Someone took a picture and it's like reflecting back on it. Skin is not that shiny. So you're getting these sclerotic type changes. You're getting tightening of the skin. Is it scleroderma? No, it is not, but it kind of mimics this. So all of these things together kind of come up into this, umbrella. Cutaneous paraneoplastic syndromes. I have to use this with caution. Why? Okay. Because seborrheic keratosis are very common. And if you see someone come in your office and they have a lot of seborrheic keratosis and you tell them, oh, I think you have the sign of Leschler-Trollat, eruptive SKs, we need to do like a full battery of tests because you probably have an aerodigestive cancer. No, they don't. They probably just have a lot of seborrheic keratosis. That's what people have when they get older. So this eruptive, this sign of Leschler-Trollat or eruptive seborrheic keratosis is a controversial diagnosis. The problem is the incidence of just organically people getting seborrheic keratosis is very high. So if someone happens to get a cancer, do they happen to have a lot of seborrheic keratoses? It's most likely just true and true. When could you? I tend to downplay this diagnosis. If I was going to give my editorial, I'm on the side of it's probably not a thing. But when would I be concerned? If I have someone who's relatively young, if someone in their 40s gets eruptive seborrheic keratosis all of a sudden, then maybe that we'd take a further look into that. Associated with adenocarcinoma of the stomach or the colon. Tripe palms, that middle picture, that is where you get sort of the accentuation of the fingerprints and they get thick. What is tripe? Tripe is a term that describes the inner lining of a cow's stomach, and supposedly that's what a cow's stomach looks like. Tripe palms, just their fingerprints get bigger. Just remember that, associated with stomach and lung cancer. And then this last one, all the way on the right, acrokeratosis neoplastica, also known as Bayes-X, that you get something in the respiratory tract, upper GI, you get this paraneoplastic syndrome. With these paraneoplastic syndromes, the cutaneous manifestations of these are generally not helpful in localizing what type of cancer you have. There are some paraneoplastic paraneoplastic syndromes where the syndrome that you get may actually help you track down what type of cancer is going on. So if someone gets SIADH, like out of the blue, you can be pretty certain if you'll go look those up and you'll say, well, this is associated with small cell lung cancer and it's also associated with some sort of intracranial tumor. So if someone gets SIADH out of nowhere, then that paraneoplastic syndrome may actually help guide your diagnosis. But these cutaneous manifestations, they don't tend to do that because look at this. These are the most common ones, and look what we have. We have adenocarcinoma of the stomach, adenocarcinoma, stomach, colon, stomach, lung cancer, upper respiratory tract, and upper GI. This is what you would get on your dermatology board exam. If you got these pictures, they would just say the answer would be aerodigestive cancer. Well, aerodigestive cancer is not that helpful because that's basically everything. I mean, you get all your digestive tract, you get your respiratory system. I guess it rules out your central nervous system and the reproductive system. But these findings are so broad that just knowing that getting these types of symptoms could be associated with something, be very cautious. What I would say is if you think you have something like this, send them to derm, let them sort of decide if they think that this is actually just retention hyperkeratosis or psoriasis, or if it's actually tripe palms or acrokeratosis neoplastica. So just be cautious with those paraneoplastic syndromes. Don't get your patients too worked up. That's all I have for my cutaneous manifestation lecture. Absolute pleasure to be here. If you guys have any questions, now would be the time to send them in.
We do have a couple of questions.
All right, I'll do my best. And with great humility, because I know that I'm told there's about 100 primary care doctors out there, so when you have an audience like this, you have to be careful what you say because there's a good chance someone out there knows a lot more about anything that I could comment on. So get ready for some hedging.
Over 130.
130.
Not everyone's primary care. We do have some dermatologists on board.
Oh, outstanding.
Thank you, Dr. Hampton, for giving us some answers along the way.
Dr. Hampton, wait, now that's not fair. No, I didn't. I hope she wasn't giving answers along the way.
But she was right, of course.
Oh, yeah. It's not fair.
Well, so there's a question that I think speaks to our relationship between primary care and our specialists. Mm-hmm. And, in our system, unfortunately, the promise of interconnected systems never happened or hasn't yet. And so there was a question about, if you think someone maybe has lupus or some kind of systemic disease, should we start the workup and send them to you with your 3 to 4 month wait? Or should we just let you do all the lab work? We also do biopsies in our offices.
That is a good question. And here's what I would say. it's kind of, here's the position that I'm in right now. I'm sort of going to be asked to speak on behalf of the Charleston dermatologic community, which I cannot do. So I can only speak for myself, and this isn't generalizable. I have my email on here, and what I tell is I try to have a very good relationship with the referring providers. Anyone who's in this lecture can send me the people who I've already met in person and I know, they all have my cell phone. And I think it's important that we're available because a lot of times these decisions are made in the clinic. And so I always just say, text me. Say, I have this in my clinic. Is this something that's urgent? I will bring people in at the end of the day without fail, that day, if at all possible. So I think we providers, we have like sort of a duty to, as specialists, we're sort of obligated to help in those situations when there's an acute issue. So that is my answer to that is we make ourselves available. That's just something that we do, and we think it's great for the reputation of our business, and it builds relationships, but it also helps patients. So that's how we handle it. I know that it's not generalizable. I'm not saying that that's the right answer. The other thing you do is I have my email on the slide. If you just email me, introduce myself, I'll also just email you my cell phone. And then you can just text me with an introduction. I can add you. It helps. But as far as doing the lab workup, what I would recommend, if you think someone has cutaneous lupus, you send them to dermatology. Unless it's compelling, I don't think I would get the labs at that time. Because of the association with, like, say, chronic lupus is low and the false positive with an ANA is high, what I would do is I will diagnose it. If it's cutaneous lupus, I would at that point sort of take over the decision whether I think this patient, I will make a recommendation to you whether I think we need to work them up for systemic lupus. If they're concerned about it, it's easy to send them to rheumatology. But where I would go is, if you have any questions, I would either get your friendly neighborhood dermatologist, send them an email, send them a text, have them try to get seen. I am very cautious, and I think usually primary care doctors should be cautious about that ANA with a reflexive ENA, just because getting that false positive is 20%. So I try to leave that decision, except in the most compelling cases of like acute cutaneous lupus, to the rheumatologist, because ultimately that's who's going to go there to sort of manage the labs.
We are faced very commonly, especially in times of COVID, with people coming in with alopecia. And the evaluation of alopecia, you look for metabolic reasons. And we were wondering about how often lupus is really one of them, because it's in the differential, and
not often.
Kind of your approach to the alopecia situation.
No, with alopecia that's one of those, it is out there, and a lot of people don't like to touch it, because alopecia is one of those things where it's high emotional impact for the dermatologist, for the patient, and sometimes there's limited benefit that the doctor can do, and so that can be a difficult thing, but there's actually a lot that can be done for these patients. In general, no. If someone has alopecia, I think that's a great derm referral, unless it's clearly something like androgenetic alopecia, which can be very effectively treated at the primary care level. But some of those alopecias, it's more of a nuanced examination. You're going to take a dermatoscope out, and you're going to look at the hair follicles, see if there's scarring changes, see if there's miniaturization of hairs, use some of these more subtle exam findings to make your determination, sometimes a forced hair pluck test, things that my overall recommendation my overall answer to that question is no, I don't put lupus high on my differential diagnosis of people who have non-scarring alopecia. And I think alopecia in general, that's a great one to refer out to a specialist, to dermatology.
It's certainly become quite an issue at my office. All different kinds of alopecia have been showing up.
Yeah, it is. And I trained at Walter Reed with Dr. Leonard Sperling, who literally wrote the book on hair pathology. I have a signed copy, and it's very precious to me. But training him was a real privilege, because it is a very confusing thing. He's able to sort those things out, and I think treating hair loss takes a lot of. I'm sure Dr. Hampton would agree with this, that it takes a lot of finesse, because it is an emotionally impactful thing, and the way that you handle it, I think, really will frame how much the patient finds the encounter to be helpful, as much as you may or may not actually be able to regrow the hair.
We had several questions that were more around biopsying.
All right.
One was, is a deep shave biopsy okay if you think it may be melanoma.
Yes.
Okay. That was easy.
Yeah,
And with squamous cell cancers, if you remove it and the margins are clear, are you done?
No. So I'm going to elaborate on both of those. So the first one was, yes, you have to use your judgment. And what I would, if you think something is melanoma, you as the person who's doing the biopsy have an obligation to try to get the entire lesion without transection, because if you transect or cut the bottom of the tumor, you have affected the ability of the pathologist to stage it, because the depth of invasion into the skin is very important in the staging and ultimately in how that patient is going to be treated. However, I would not, this is sort of, some people are going to clutch their pearls at this. However, in my opinion, if a primary care doctor does a biopsy and transects the base of something and it may interfere with the staging, I'm happier with that than if they just didn't do the biopsy at all, because at least you have the diagnosis. You can always, there's ways that you can do a larger excision or an excisional biopsy. If it's a big thing and you're not comfortable because you don't have the experience with assessing the depth of a shave biopsy, sure, you could go with a punch. Or if it's really big and it needs to be cut out with a scalpel, then I would talk to your dermatologist friend and have them square that away. For squamous cell, I would say generally no. You do that biopsy. When the pathology specimen is sent to the pathologist and they bread loaf slice that on FOSS, they're generally looking at about 3% of the actual cross section of the tissue. So you want to have an actual surgical, in general, 4 millimeter margin around a squamous cell, or you want it to be cleared with Mohs. However, there's always the NCCN guidelines, which are used to sort of guide dermatologists and other physicians on how to manage melanoma, non-melanoma skin cancers. They have those algorithms, and the algorithms will say biopsy and then get margin control, Mohs, surgery, radiation, something like that. However, we have patients who the morbidity from an excision or from Mohs is very high, and they're 88 or 95 years old, and the juice just isn't worth the squeeze. If it's on their leg and you're going to do an excision and you know that it's going to fall apart because the leg just heals terribly and they don't have the social support at home for wound care, could I be convinced that it's a reasonable thing to do, that you did the biopsy on this patient who's a poor candidate for surgery or radiation? You did the biopsy and the margin says clear. Talk to the patient about it. Say, listen, I think you're a poor candidate for surgery. It's clear on the biopsy. Good to go. Is that good with you? Yes, good. Great. I mean, those are guidelines, and you have to use your judgment, your intuition, and that's sort of the most important part of your job. It's not to just follow the chart. It's to actually make the patient's life better. Any other questions?
Well, everyone wanted to know where you have your office, and it's James Island, and you're opening up on Johns Island soon?
Yes. So right now we have an office on Ellis Oaks Drive, so it's just off Folly. So over by the Lowe's home improvement store is where we are right now. That's where our main office is. And then, yeah, we're opening a little satellite office out on Johns Island because a lot of our patients commute out from Johns Island. So we are really trying to be as accommodating as possible because everybody hates traffic, and it makes more sense for us one person to commute 20 minutes than for 20 people to commute 20 minutes.
And also, Dr. Hampton put in the chat that, she too would like folks to give her a call if there's something urgent to be addressed, and they'll try to get people in as soon as possible. And that certainly has been my experience with her.
Yeah, I think that in general, when I meet primary care doctors and I'm talking with them and I'm establishing that relationship, there is more of a hesitancy to contact the dermatologists. They feel like they're imposing more than they actually are. Like, we're here to serve the community. We're here to help patients. That's what we're here to do. And collaborating with other physicians on interesting cases is actually kind of fun. It's nice to do. And so I would encourage people to feel very free about reaching out, either myself, Dr. Hampton's making herself available. I get a text or a call every other day, and it really makes me happy because for some of these things, especially like when I have cutaneous manifestations of psychiatric illness, I need your help. I need to have a good relationship with you and with most of the providers who we work together enough that we're on a first name basis. It's so much easier when we can send them an email, we can coordinate the care, and it means a lot to the patient that both people are on board. So no one in this room needs to convince me that that collaboration is important. And for a lot of the people who are there and collaborate with me know that, sure, you text me. If I don't get back to you within 30 minutes, I'm sick or dead. And so people definitely take advantage of that. If Dave is in the audience, or you do that.
Vacation too is an option.
But what's vacation?
Well, when you're in practice, who knows, right?
Yeah, we'll see.
Yeah. Well, thank you so much for this wonderful information. We really appreciate it. I know it was a difficult topic to give someone, and you handled it very beautifully. Thank you.
Yeah, I mean, overall, dermatology is easy and primary care is hard. So if we can make it as easy for everybody as possible, then we all benefit. But it's a pleasure to be here and honored to have the opportunity.
Thank you.